Dr. Mindy Scheithauer is an associate professor at Emory University School of Medicine and a psychologist and behavior analyst in the complex behavior department at the Marcus Autism Center. Dr. Scheithauer is an established researcher focused on developing novel extensions to function-based assessments and treatments using both single case and clinical trial research designs. She has conducted research and presented on the assessment and treatment of elopement and serves as an editor for the Journal of Applied Research in Intellectual Disabilities. These webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website at autism.org. Now I will turn this over to Dr. Scheithauer.
Hello, everybody. I'm very excited to be here talking with you all, and I appreciate that wonderful introduction. So today we're going to be talking about elopement and specifically what it is, as well as some safety tips and considerations for programming. A little bit about me to start with. You already got a little bit of a bio, but I do like to highlight that part of what I'm bringing to this talk is from my professional experiences in two different categories. Specifically, I am both a clinician and a researcher. From the clinical side, I work at the Marcus Autism Center and I work in our complex behavior support program. This is a program that's exclusively dedicated to the treatment of complex behaviors such as aggression, self-injury, disruptive behavior, and elopement. So I have a lot of years of experience in working directly with children, as well as doing more parent training types of interventions to focus on these concerns. That clinical experience is very directly related to my research experience. So my research goes through Emory University, and in that role, we have some grant-funded research that I'm going to be talking about today that is really focused on translating what we have done clinically that works, hopefully in packages that are more easily exportable, that are then accessed by more kids outside the walls of Marcus. I do have some funding that has helped with this project. So the Autism Speaks treatment grant funded the bulk of the data that you're going to see today. As well, the National Institute of Child Health and Human Development funded a pilot study that led to this work. And then I do like to highlight that I have a clinical appointment at Marcus where we deliver these services. So what we're going to get into today. So I'm going to start by talking about the impact of elopement, what I mean by elopement, why we should care about this behavior. Then we'll get into the current state of the research on this area. I'm going to then go into some pretty practical recommendations just around prevention and reducing risk if elopement were to happen, and then talk a little bit about assessment and treatment. Now, assessment and treatment of elopement is a very broad category that can't quite be covered in an hour. However, I'm going to try to hone in on a few kind of key components so that if you are a clinician in the audience that is working with kids who elope and you are doing more systematic behavioral intervention, you have some idea of how that looks different for elopement than it would for some other behaviors. So what is elopement? Elopement is any time that a kid is leaving supervision. So wandering, running, bolting away from supervision. This looks very different for different kids and across different settings. So for some kids, this looks like leaving the house. There's a lot of stories of kids who are awake in the middle of the night and leave their homes without their parents knowing. Or a mom is doing dishes, they turn around, a dad is busy on the phone, they turn around, all of a sudden, their child's gone. So it can look like leaving the home. It can also look like bolting away in public. So maybe you are at a park with, child and siblings, everybody's playing nicely. All of a sudden you don't see child anymore. So that is also a situation of elopement. It can happen in public. So getting lost in a grocery store or getting lost in a mall. From school, so it might look like leaving a classroom or running away in a hallway. A lot of times this is occurring because of specific interests, so repetitive or special interests. We often find that children elope to get to something that maybe their typically developing peer wouldn't care so much about. So for example, a child that elopes to go to a water source or that goes to look at a train or something that they're particularly interested in. It can also look like running around the neighborhood. So sometimes it looks like, you have the kid outside in the yard playing and all of a sudden you turn around and they're a few yards over. This behavior is very, very prevalent. It's very prevalent in autism. I do like to highlight that elopement is developmentally appropriate when it happens infrequently and only until about age 3 or 4. A lot of kids have a story of getting lost in a grocery store or something like that. However, in autism, it tends to persist. So almost half of kids with autism are still eloping after the age of 4, whereas their peers have often kind of outgrown the behavior at that point. And about 35% of kids with autism have eloped in the past year. So meaning it's happening pretty frequently. For a lot of kids, it's not like a one-time thing that happens. Elopement is terrifying. It's scary for parents. It's scary for clinicians. It has a lot of negative impact, meaning that there's a lot of reason that we should be trying to prevent it. A survey that McLaughlin did in 2018 of close to 1,500 caregivers of autistic youth found that of caregivers who had a kid that eloped, about over half, were at risk of serious injury. A lot of them were avoiding public places. And what's most concerning is over 40% had no guidance for what to do. We all have likely heard of terrifying, terrible stories in the news of a child who elopes and drowns or elopes and gets struck by a car. And what we're seeing here is that a lot of children who elope put themselves at risk of those types of injuries. And then again, what we found particularly concerning about this study was how many parents were saying in the survey that they didn't know what to do about it. And so this kind of led to a lot of the work that we've done in the area to try to make tools that hopefully more clinicians are eventually able to use. Okay, so what I want to talk about next is the current state of research, specifically as it relates to treatment of elopement. So function-based elopement treatments. What I mean here are treatments that are based in behavior analysis. A lot of people are familiar with ABA as it exists in the world of kind of building skills, meaning like kind of the traditional ABA where you might have like a registered behavior technician sitting across a table from a child and kind of teaching them different language skills or pre-language skills. Those are very important ABA services. However, behavioral services also work to decrease inappropriate behaviors. The model looks a little bit different, but it is still the same principles that are at play. What that involves is it starts by identifying the function. So all behavioral treatments for elopement are going to start with figuring out, why is the child eloping? This is really, really important. I'm going to talk about prevention strategies in a little bit. But at the end of the day, when a child is eloping, they're doing that to tell us something. So they're trying to tell us, for example, I want to go look at something outside. Or in a lot of situations, they're saying, whatever is going on in here is overwhelming and I need to get away from it. So they're trying to communicate something by eloping, and it's important that we figure out what that is. Generally, that is done through a functional behavioral assessment or figuring out what is setting the child off, what is causing them to elope, and what are they eloping to. And looking at those variables helps us understand why that child is eloping. After that, we're going to teach them an alternative and appropriate behavior to get what it is they need. So for example, let's say that the child is eloping from school because school is too loud and it's very overwhelming from a sensory perspective. We might teach them an appropriate request for noise canceling headphones. Or if a child is engaging in elopement because they want to go outside and look at something, we might teach them how to ask their parents to go outside with them. And then of course, teach them to wait if they can't do it right away. But teaching them another way to get what it is that they want. After that, we change the environment to promote that appropriate behavior. So you can often kind of think about this as a scale. What we want to do is maximize what the child is getting when they engage in the appropriate behavior and minimize what they're getting for elopement. So, if they ask the parent to go outside and look at something, then they're going to get to go do it at least most of the time. If they try to run out of the house, the parent's going to stop them and not let them go look at what they want to look at. So it's all about kind of changing the environment to promote that appropriate behavior. And then we're going to generalize and we're going to work on maintaining. What we mean here is a lot of times we can get the elopement under control in this nice clinical setting, but that doesn't really matter that much to the parents or family. So the next step is to make sure the treatment actually works when you're in the grocery store, when you're at the park, when you're at grandma's house, and that the progress maintains over time. For anybody with a more behavior analytic background, the technical terms for what I'm talking about here are some kind of a functional analysis or a functional behavior assessment to figure out why the child is eloping. We are often then doing functional communication training to teach them to ask what they want. We then set up a differential reinforcement environment to promote that appropriate behavior, and then move on to generalization and maintenance. The good news is we know that these treatments work for elopement. Lang and colleagues back in 2009 did a literature review on this topic. They found 10 studies, mostly single subject or small n studies, but 53 participants total who had undergone this general behavioral paradigm in order to treat the elopement. And what we found is that 80% of those studies had positive results. Dr. Call, who's here at Marcus, and myself and some other colleagues then did a consecutive case series analysis, meaning that we looked at the last 11 kids that we treated for elopement, regardless of if treatment worked or not. We just took the last 11 that we treated and looked at their outcomes. And what we found is that comparing their elopement at the end of treatment to the beginning of treatment, we got over a 90% reduction in elopement for a little over half of those kids, and 9 out of 11 had at least a 70% reduction in elopement. So again, we have some evidence that these behavioral treatments work for elopement. However, the literature up until that point had some significant limitations. So what is the individualization? I show this nice 4-part kind of treatment, but there's a lot of details that you're not getting in this. There's a lot of, what appropriate behavior they were taught. How did they teach it? What did we change the environment to? So there's lots of kind of little nuances in this that were different across all of those studies in the meta-analysis, as well as all of those clients in the consecutive case series analysis. The reason that's an issue is when people who are not super familiar with treating elopement try to replicate what we've done, it's hard because everything's a little bit different. So we, as a research group, started brainstorming what's a solution to that. One solution to that is to manualize an intervention. So to take all of those strategies from past research studies and put them into a more structured format, still allowing for individualization because each child is unique and there is not going to be a one-size-fits-all treatment, but trying to kind of structure if this, then that, and if this, then that, so that things can be a little bit more easily replicated. Another limitation in this past research was it was really all done by people with pretty specific training. So mainly people like myself. My whole career has been dedicated to treating these behavioral concerns. That's what I did in graduate school. That's what I did in postgraduate training. It's what I do now. So there was a question mark about sure, it works when somebody with years of training does it, but would it work with somebody who maybe doesn't have years of training? And so the goal that we put forward was not only were we going to try to manualize this intervention, but we wanted to do so that somebody with behavioral training, so a board certified behavior analyst, for example, so somebody with that background, but without specialized training in treating behavioral concerns could hopefully pick it up off the shelf and use it. We also wanted to avoid specialized settings. So a lot of the treatment to date has been done with these really ideal clinical settings, and we wanted to make sure that treatment didn't need that. And then disseminating. So a lot of the research up until then was done with small n or single subject design studies, and that just doesn't make its way out of the behavior analytic field as well as some other types of research designs. So we wanted to do this with a larger sample as well. So what that resulted in us developing is the Function-Based Elopement Treatment Manual. You'll hear that abbreviated as the FBE Manual. What this involves is a therapist. So the appointments are held 2-hour weekly appointments that are caregiver mediated. So you can really think about it as the therapist or the behavior analyst is a coach for the parent. The goal then is that the parent between the appointments is practicing things with their child and implementing these strategies so that hopefully the child is being exposed to the treatment setting much more than once a week, but it's only a once a week scheduled appointment. The manual is very extensive. It's over 200 pages. It involves therapist scripting for all of the different training components. It involves a lot of templated protocols. So we do a latency-based functional analysis, which I'll talk about later today. And that has templated protocols as well as ways to graph data. It has a lot of troubleshooting tips. So a lot of, again, there is not a one-size-fits-all treatment here. So there's a lot of, okay, if you hit this barrier, this is what to do. If you hit this barrier, this is what you have to do. And then it also comes with a caregiver workbook so that the parent can really follow along. Most of our research is with parents. I like to say caregiver because there are times that there's grandparents or other kind of caregiving arrangements. The full manual, I will say, is coming soon. I'm going to talk about the current state of the research, but we are hopeful that in the next, 4 to 5 months that it will be available to the public. So that we're hoping to get this out soon. That is the goal of this research, is to be able to put this manual in the hands of clinicians. So getting into a little bit more of what those 12 appointments really entail, the first appointment is really just a program overview and providing caregivers with a lot of education about what elopement is. In the second appointment, we design the functional analysis. That is the assessment that we are doing to figure out why the elopement is occurring. We also put together the home elopement safety plan. The home elopement safety plan is based on a checklist that the parent fills out. That I'm going to go through that a little bit more later, but it's basically a bunch of different strategies that say, if elopement occurs, this is going to keep the child safer. We then create a plan for getting all of the things in place that are not already in place. And then each week we follow up on that plan. So in addition to the behavioral strategies, every week we're reviewing with the parent, like, okay, so we had the goal of getting locks on the front door. Did we get that done? If not, why not? Let's troubleshoot. So kind of helping with that safety aspect. We also have the parents start collecting data on their child's elopement, the antecedent behavior consequence or ABC data, and that happens throughout the first few weeks. In appointments 3 and 4, we coach the parent through implementing a latency-based functional analysis, which I'll talk about what that means in a bit. Appointment 5 is generally spent putting together the nuts and bolts of treatment. So taking what we've learned about the child so far from the data the parent collected and from the functional analysis and putting together an initial treatment plan. And I'll talk about what those components are in a moment as well. And then we will get into actually practicing the treatment itself. So the rest of the appointments are held with the therapist saying, okay, let me see what this looks like. Sometimes this is at home. A lot of times it's not. A lot of times it is going to a grocery store. Sometimes it's telehealth and you're following them, via camera to the grocery store, wherever elopement is happening. And you're watching them practice treatment. We then start to do things like fade out the reinforcers so that hopefully they don't have to be getting a reward for not eloping forever, adding treatment components, and then at the end we have written recommendations of everything we've reviewed. Okay, so how we actually wanted to go about analyzing this. So as I mentioned, there were a lot of single subject demonstrations that already showed us that this general structure should work. We didn't necessarily make up the components that are in the manual. We just took everything that was already in the literature and kind of summarized it in one spot. So once the single subject demonstrations were done, our next plan was to do a feasibility clinical trial. So we wanted to see, could we actually evaluate this in more kids at once? So there's a lot of kind of ifs when you start to do research in the clinical trial world. One is, will parents even be willing to sign up and get randomized? All parents are incredibly busy people. I have 2 young children. I can empathize with how busy life is. And then you add that with all the other appointments that individuals with autism tend to have and all the other complications that get thrown in there. And we want to know, will parents even sign up? And we wanted to know, will clinicians follow the manual, or will they get halfway through it and say, throw this out and do what they normally do? So that's the first study that we did. And this study was published back in 2021. But specifically, what we found is that we could recruit and therapists would follow the manual. And we found that parents generally liked the treatment. They rated it as pretty acceptable. We specifically found that about 91% of appointments got completed, so pretty good. On a caregiver satisfaction measure, we averaged a 6.7 out of 7, so they tended to like it. And therapists, about 92% of the time, followed what the manual told them to do. So pretty good outcomes. We also got some preliminary outcomes showing that a little under half of the treatment group improved. So this is based on kind of a blinded evaluator's rating. So somebody that doesn't know what group the family is in, but just talks to the family about the child, about elopement, looks at some questionnaires they fill out and make a rating. So I do like to highlight here that this is not 100%. I never want to missell this treatment to act as if it will help for every single child that elopes. And I'll talk about that a little bit towards the end. So now that we found feasibility clinical trial, check, we could do this, then we moved on to an efficacy clinical trial. Specifically, let's do this with a lot of kids now. And so this study enrolled 76 participants, half of whom received this function-based elopement treatment. The other half received a parent education program. In that parent education program, they were still meeting with a clinician once a week, but they were reviewing general topics about autism. So things like how to read a diagnostic report, how to work with the school system. So things that should be helpful, but aren't directly focused on elopement. The reason we did that is we wanted to make sure that this treatment works better than a treatment that is really just focused on, talking to a parent about their child. We want to make sure that it does provide more than that. Okay, and then we measured, so the functional-based elopement treatment compared to the active control, and then we measured the child's behavior in a few different ways at the start of treatment and then again at the end, or baseline and endpoint. Okay, so that is the study that we recently completed. Now, I want to talk about the outcomes of that study in two different ways, and specifically, I want to talk about them as they relate to preventing and reducing risk, as well as assessment and treatment considerations. So as I mentioned, there's kind of two parts of this treatment. One is just making the home safer, or the environment safer, but it's not necessarily saying we're going to stop the child from trying to elope. We're just going to make it so that if they do elope, it hopefully isn't as harmful. That's the preventing and reducing risk. And the outcome that we have related to that is more of a safety outcome. The other part of the treatment is focused on let's actually stop how often the child is trying to elope. And that is really the behavioral assessment and treatment components, and then the specific elopement outcomes associated with that. And I'll kind of pair those together. So prevention strategies. The way that this kind of works is at the beginning of the study, all parents, both in the control and in the treatment group, are filling out a checklist. And it has prevention strategies in three categories: physical prevention, reducing danger, and response readiness. So physical prevention are things that involve like actually making it so the child isn't able to get away from a parent. Reducing danger is like, okay, now they have gotten away. How do we make sure they don't get hurt? And then response readiness involves now let's make sure we can get them back to their parent as quickly as possible. I'll go through some examples in each of these categories, but the key is the parent fills out a checklist where they mark yes or no, whether or not this long list of things are currently in place. The therapist then gets access to that. And at that second appointment where they do the planning, everything that is marked as no, that the parent thinks would be helpful to have in place, gets transitioned over to a safety plan. And then each week we're touching base on the safety plan and trying to kind of progressively work on each component. So going into a few examples of each of these categories. Physical prevention, the goal is to prevent or slow down elopement. The key ones here are usually things like locks or alarms in the home. So locks on doors and windows. If the parent can't install locks, or if you just have a kid who is incredibly clever and is going to get out of the locks, at least having alarms so that maybe you at least know if the child's going to get away. There are a lot of ways to get creative here. These aren't necessarily tested. I'm not endorsing them, but they're all things that I have seen parents use with some success. Sometimes it's going back to like the traditional baby type locks that you might have used when kids were younger, kind of getting those back out of the closet, and sometimes that's enough. Sometimes you need to add them to windows as well to slow kids down from that way. Sometimes it's very simple locks, but put up higher. So a lot of times when kids have outgrown these kind of baby locks, it's about taking like a fairly traditional lock, but putting it higher on a door so that they can't actually reach it. I've also had a lot of parents use alarms like this with success. This is it's basically just a mat that you could put like under carpet or underneath like a welcome mat. and it alarms when someone steps on it. So it's a fairly kind of rudimentary technology, but especially if you can get it so it's pretty ingrained underneath like a carpet, it should alert you when the child's leaving. There's also low-cost strategies, things like putting putting bells on a door so you at least hear if it gets opened. Lots of different strategies like that. This is in no way an exhaustive list. I just like to show a few examples because every once in a while I talk to parents that say, we've tried locks, it didn't work, the kid got out of it. If you go to Amazon and Google, locks for doors, there are hundreds of options. So even if it hasn't worked once, don't give up. Keep kind of trying. There might be ways that you can make the home a little safer. Now, outside the home, this gets a little bit more complicated. The best way is if you can increase supervision, recruiting the help of others, especially if you have a child who only elopes in those really crowded places. Like, can you save that trip to Walmart for a time that aunt or uncle can go with you to kind of help keep an eye on the child? I understand that that's a little idealistic. A lot of parents don't have that kind of support system, but that is one option. The other thing to consider is GPS trackers. This depends on each parent's own comfort level. I do understand that some parents are concerned from like a child privacy perspective, and I hear that. But if the child's really at risk of getting lost, the safety aspect might kind of counteract any privacy invasion. Either way, I like it for clinicians and parents to know they exist. There's ones that are watches that kind of work the same way any smartwatch works, that you can have it connected to the parent's phone and it can go from there. However, a lot of kids don't like to wear watches. They do have ones that actually can get sewn into clothing. So those are kind of good options. You can have like special clothing that has special pockets for them and things like that. Angel Sense is a company that does some of this. There is like a monthly, I think it's a monthly kind of fee for it, but there are some companies that do some of this work specifically for kids with autism that elope now. The other area that does a lot of work in this is Alzheimer's. So individuals with Alzheimer's also have significant concerns with elopement. And so sometimes if you have a kid or maybe not even a kid, maybe an adult that you're caring for, some of the autism specific ones are geared towards kids. Some of the ones meant more for individuals with Alzheimer's are more geared towards adults. So that's kind of another kind of Google search that you might do to find some of these GPS trackers that can be really helpful. Another thing here is teaching. So another skill that you're going to want to do to kind of reduce the chance of harm if the child does elope is making sure the child can do things like report their name and phone number. If the child gets lost and someone finds them, these are the first questions that someone's going to ask them. Some kids can be taught to kind of use vocal response. Other kids might not. If you have a child who doesn't quite have the communication skills yet to respond vocally, you might at least find a way for them to wear their identifying information, ideally at all times, so that if they do elope, somebody has a way to find out who they are and who you are. Also, you can teach the child to point to it. So teaching a child to report vocally their name and phone number might be a really big task. Teaching them when someone says, "What is your name?" for them to point to a bracelet is an easier task to teach. They make some that are actually for this purpose that are a little bit more difficult to remove. I will say anytime I see something that says like it's childproof, it can't be removed, I always kind of have in the back of my head like I'm pretty sure I have found a child who could get that off. But they do make them so they're a little harder to remove, and that might be helpful. If the child isn't going to remove it, you can also just get, those little kind of rubber bracelets that you can get for really cheap and just with a permanent marker, write the information on it. If the child won't wear a bracelet, but they're likely to keep their shoes on, there are shoe tags. Similar, the cheap version of this is to just print the information, laminate it, or put contact paper on it and punch a hole in it, and then you can kind of string it through their shoelaces. They also make temporary tattoos. This is probably not going to be something you use every day, but let's say you are going to Disney World and you're worried about elopement there, you could get some of these, and it's just, again, makes it much less likely that they're able to kind of get out of it. In terms of physical risks, there are other things to consider here. One of the biggest risks for elopement is drowning. I know that's really scary to think about, but if you have a child that elopes, especially if that child is interested in bodies of water, doing swim safety as quickly as possible. That way, if they do get into a lake or a pool, they at least have those skills. Teaching them to safely cross roads is another one, especially if you live near a busy road. You might not think to teach a 6-year-old how to safely cross the road because you're always going to be with them. But if they elope, you might not be. And so you might want to start teaching some of those skills. In terms of how you're going to teach this, there are going to be times that it falls on a parent to teach, but you can also get other individuals in the child support system. So, for example, you might advocate that the child learn how to report their name in an IEP. That might be kind of a good skill for the school to work on. It might be a good skill if the child's in ABA therapy to have them work on in that context. And then, of course, it's also something that you can teach. So, if you're out walking, teaching to cross the street, but it's not all on a parent necessarily. And then response readiness. So this is tough because a lot of times parents and clinicians don't want to think about a child being lost because that's terrifying. The idea of thinking about your not knowing where your child is so scary that it can be easy to want to ignore it. However, if your child elopes, it's going to be even scarier if it happens and you haven't planned for it. So we also really encourage parents to fill out things like elopement emergency forms, information that has like a recent photo of the child, their name, do they respond to their name, any kind of specific vision impairments, anything like that that someone should know about. What do they like? What do they dislike? Like if the police are going to be involved in looking for your child and your child's going to run as quickly as possible away from a siren, that's something that would be good for them to know. Who should be contacted and how should they be contacted? Again, if you are responsible for a child that goes missing, your brain is going to be going in a million different ways. So having this information written down so that you can hand it to somebody and you're not trying to piece it together in the moment can be a really important tool. Other things to consider is who might help look. So if you know your child is likely to leave the home, do you have neighbors who would be willing to kind of be on like a phone chain that you could quickly call an alert to kind of help find the child? And where should they go? If your child has 6 favorite places in the neighborhood, could you have 6 people on a call list, each who know exactly where they're going? So kind of having this plan in place is helpful. Sometimes parents can even use like other parents of other kids with autism, and they can all kind of be on each other's plans, which can be helpful. I will also highlight that we did not create this from scratch. A lot of these strategies have been available for a long time through the Big Red Safety Toolkit, which is a resource that is freely able to be downloaded by anybody online. It is a great resource. We've kind of taken some of the strategies and modified them, but this is a really good tool for parents to consider. This is just an example of what the elopement checklist looks like that we have parents filled out. So for example, we do ask them, like, do you have locks? Do you have alarms? Can the child cross the street? And then I want to highlight the outcomes here. So one thing that I think is important to note is that Big Red Safety Toolkit and other similar resources that are available are generally available for parents just to download online and kind of try to use themselves. Because that's kind of standard of care, in our clinical trial, in our control group, so in the parent education program, during appointment 2, we went through the Big Red Safety Toolkit. So we went through this resource with the families and we went through it in detail. Like we reviewed it for about an hour. In the treatment group, that's where we went through this checklist like item by item pretty much every week for 12 weeks. What we found is that blue line shows when we were checking in on it weekly. That shows our treatment group. The red line shows our control group, where the parents were basically handed the resources and kind of talked about it for an hour and said, go home and try to do this. What you see on the y-axis here is the percentage of items on that checklist that the parents endorsed having in place. You can see at baseline, both groups are around 25-ish% of items that they had in place. But then what's interesting is that the treatment group jumps up to about 65. So they make a lot of progress in getting these safety procedures in place, whereas the control group really didn't. And that's not surprising. We are all given so much information in life, and then parents of kids with autism are given so much more that it's not surprising that handing a parent who probably has a million things going on this big packet of information saying, like, go home and do this, that it ends up on a shelf and it ends up not necessarily happening. And so I like to highlight this because if you're a clinician working with a child who elopes, definitely checking in with parents about these resources, but then helping come up with a plan and helping them prioritize like what they're going to do and when might really increase the likelihood of things getting put into place in a reasonable time frame, and not kind of taking the back burner to the millions of other requirements and checklist items that are given. Okay. So then the last thing that I want to talk about today before we open it up for some questions, and I'll try my best to leave at least 10 minutes at the end for some questions, are assessment and treatment considerations. So again, I'm not going to be able to go through the entire behavioral treatment manual in the next 15 minutes, but I do want to highlight some of the things that are kind of unique about this treatment compared to the way that we might go about treating a meltdown or treating aggressive behavior, some of those other kind of complex behaviors. So a latency-based functional analysis. So the way that we are assessing why the elopement occurs is by exposing the child to different situations and measuring how long it takes them to run away. So for example, to evaluate, some kids run away because they like the reaction it gets. You can kind of think about this as the kid that's like running away in the grocery store and like laughing as the parent tries to chase them. That's kind of this category of behavior. What we do to test for that is we have the caregiver say they're busy, have them kind of divert their attention to something else. If elopement occurs, then they chase after them and provide a bunch of attention. But the key is that they don't get a bunch of preferred items and we're not asking them to do things they don't want to do. In the tangible test condition, we might take the child somewhere that they like, tell them that it's time to leave, and then if they try to run away, let them go back to it, for example. The goal here, though, is that to isolate, this condition from another condition, we would try to not give attention or give a lot of instruction. Last, we'll test if the child is running away to get out of something because they don't like something that's happening. That's called the escape condition. For example, we might tell them to do their homework, and then if they immediately run away, then we might give them a break to see if that's why they're doing it. Now, these conditions look pretty much identical right now to how they do if you were doing a functional analysis of any behavior, of aggression, of self-injury, of disruptive behavior. However, what we find is that with elopement, it is a lot harder to isolate these variables. And that's because of the nature of elopement requiring a change in movement. So for example, you see that when we're trying to test to see if the child is trying to get something, that tangible condition, or get out of something, that escape condition, in order to really test that, we need to make sure that they're not getting any attention for the elopement. That's often not possible. If a kid is like running out of a grocery store into a parking lot, you have to stop them. You also might have to like bring them back, which then creates a whole other kind of confound. Another one that is tricky is that a lot of times elopement does automatically remove the child from the situation. So let's say that you're trying to see if a child is hitting to leave a busy birthday party. Well, when they hit you, you are then in control of removing them. So you can kind of isolate that variable. You can't always do that when them leaving automatically removes the aversive situation. Same thing with tangible items. You might not be able to control what they're looking at when they run away, for example. So one thing that's different in the manual compared to the way that a lot of clinicians generally might do more of like a functional analysis is that we often are doing testing for just one thing in one setting. And then we might go to another setting to test another thing. So for example, if you are trying to attest for the impact of attention on elopement, you might do that in somebody's front yard where there isn't like a playground that's right next to them and there isn't anything like loud or crazy going on that they might want to run away from. When you move on to kind of more of like to test if the child is running away to get something, you might do that more in a playground area. So a lot of our kids will elope to get to a playground. That might mean that the best setting to test for that is at the playground, but that might not be the best setting to test for elopement that happens to get away from something. So you might, test for access to the playground specifically in that setting. And then escape you might do in like a community context. So you might say, maybe the child elopes from restaurants because it's loud and they don't like it inside. Well, then maybe you just test for escape in that context. So again, this is just a little bit of a difference for the clinicians in the environment of how we often assess elopement, especially in community settings, as opposed to other behaviors. So moving to treatment, a few kind of tips to consider when formatting treatments for elopement. One is you should always start with setting really clear rules. Elopement compared to aggression, for example, is interesting because running is socially appropriate, and running some distance from a parent is sometimes socially appropriate. Compared to something like hitting, it is hardly ever socially appropriate to hit somebody. So normally that behavior is kind of easier to define and easier to explain when it's okay and when it's not. Now think about especially like elopement from a playground. If you're at a playground, you don't want the child walking right next to a parent the whole time. So then it gets complicated. It's like, well, is it 5 feet? Is it 10 feet? Is it on the playground equipment? Is it in the mulched area? Is it as long as the parent can see them? So it's important to set clear rules and then walk through those with the child. What you don't want is difficulty treating elopement because the child doesn't really understand what counts as elopement and what doesn't. So for example, you might use a landmark. In the picture there, you might explain to the child that they can stay in the mulched area and they can't leave the mulched area. Sometimes you need artificial boundaries. I have had parents that we've recommended that they bring jump ropes with them or other rope with them so that they can actually create a physical boundary for the child and say, like, you cannot cross this line while you're playing. Or if you're in a clinical setting, you might like move around furniture. Sometimes you can kind of create like a furniture barrier that can make it a little clearer to the client. Social stories are another good recommendation. There is not a lot of research that shows whether or not social stories on their own help with elopement, but we generally take the view that they are not going to hurt, and they can certainly help teach a child, why elopement is scary. There's a lot of examples online that you can pull from, and so I always recommend pairing them with the rest of treatment so that you are teaching that kind of safety component while you're doing the rest of the treatment recommendations. Always consider sensory sensitivities. There are individuals who elope because there's just too much going on. The amount of sensory stimulation in their environments is too high and they're leaving because of that. So in these situations, we can certainly do some preventative strategies so they can't, put themselves at risk of safety or danger issues. However, we also just need to make the environment more conducive to them. So the environment needs to be changed to better adapt to their specific needs. So for example, can we just make the environment less noisy if that's what is concerning? If it is that there is somebody in the environment that they're eloping from, can we find ways to separate them? So always looking at, what is it that this child is trying to get away from and how can we change that instead of changing the child? Also, do you have to go to that situation? So sometimes there are situations that, the child is eloping from and maybe they just don't have to go there. It is okay for a kid to just not go to an amusement park if that is just terribly overwhelming. Or can you do it in small doses? If the problem is that the child elopes in the grocery store, but only after you've been there for an hour, can you break up the store trips and do them in 2 30-minute trips? So again, always thinking about like, is there ways that we can change the environment to better adapt to the child? And then always consider the relationship with fear and anxiety. This kind of goes back to the fact that we did find that this treatment was effective, but for about half the kids. That means that there are individuals who elope that this treatment isn't right for. The individuals who fall into that category. One is if the child is eloping and it's really coming from a place of fear and anxiety, if they have the prerequisite skills to participate in more kind of psychotherapy, cognitive behavioral therapy approaches that get to the root of that fear or anxiety, that's going to be better than a behavioral intervention. So for those individuals, they should go that route. Also, a once a week caregiver mediated intervention for really severe elopement might not be enough. There will be some kids that just need more hands-on work with a therapist. Normally for cases that are more complex or more severe, I very much view this manualized intervention as like a first line, but then if a kid isn't responsive, it might be that they need a more intensive treatment program. Okay, and then one of my last kind of considerations here is to always take a strength-based approach to this care. We want to make sure that we are looking at the child as a whole and not just saying like, okay, this child is eloping, the elopement is dangerous, so we need to stop it. We really want to look at the child holistically. The child likely has a lot of strengths. We can capitalize on those strengths in treatment. If they have some really focused interests, that might be something we can incorporate into rewards or into other kind of parts of treatment. And we really want to get the child's input. So whenever possible, get the child involved in treatment planning. I always like to say that nothing that we're doing in these behavioral interventions should be a secret to the child. If we are setting up some kind of a reward to make it more likely that they ask to leave the house instead of running out of the house, they should have a say in what that looks like. They should have a say in how it's set up. If they don't have the expressive vocal ability yet to really have a say that way, we should pay attention to their affect and what they're smiling at and what they're not. It's good to kind of get the kids involved and kind of keep them involved often throughout this treatment planning. And then the last thing is just like what the actual treatment components look like. I always keep this last because I like to give the caveat that it is best to program this in collaboration with a behavior analyst. These are kind of the core components, but there's a lot of different versions of it. And so if your child is in ABA therapy, or if you're an educator and there's a behavioral therapist at the school, incorporating them into really making this comprehensive treatment program, of course, with your input, with your heavy input, is best. But what the core kind of components generally look like is always labeled praise. That's in every one of our treatments. So making sure we're providing a lot of high quality interaction when the child's engaging in appropriate behavior. Making sure that they have something that they can do when they are not eloping. In the ABA world, this is called a synchronous schedule of reinforcement. But the idea here is like, let's say the child is most likely to elope when they are walking to the cafeteria or when they're in a grocery store. Give them something that they can do that is kind of distracting in that environment. So it might mean, they get to like play with a little figurine or listen to music or something that they can hold on to so long as they aren't eloping. If they do elope, that gets removed until they're walking nicely again. So it's kind of meant to be like a distraction item that they can have so long as they are engaging in safe behavior. And then some kind of a large reinforcer if no elopement occurs. We call this a differential reinforcement of other behavior. So this might look like, okay, if the child can walk from the classroom to the cafeteria without eloping, when they do get there, they get some kind of a special reward, something that they really get as like a good job, something they can earn, something they're excited about that they get when they get there. In a perfect world, it's matched to the reason they elope. So for example, if they're eloping because it's too loud, maybe actually as soon as they get there, they get to take a break, and they get to take a break every 5 minutes or something like that. If they elope because they like the reaction from a teacher, maybe a teacher sits next to them and provides a lot of really high quality praise so long as they're kind of staying where they're supposed to. This is key. You want to start small with a lot of repetition. So if you are working with an individual or your child likes to run away in Walmart, do not start in Walmart. Start in a Dollar General or a CVS or a much smaller store. Don't start with an hour trip. Sometimes this literally looks like, all right, I want you to walk and touch the front door of the store and then walk back to the car, and then you get a really big party for not eloping. Once that's going well, now you're going to walk in and walk to the front of the aisle, back, big party. Now you're going to walk to the end of the aisle, back, big party. Now we're going to do 5 minutes in the store, 10 minutes in the store. So it's really starting slow and then a lot of repetition. These treatment strategies do not work immediately. This involves, a lot of repetition of getting the child more acclimated to the setting and kind of building up that history of getting things that they want when they're behaving in safe ways. So it's definitely not something that starts quickly. And then you want to minimize reinforcement if elopement does occur. So if the child does elope and you're in the store and they run to the toy aisle, try to get them out of the toy aisle. Don't buy them a toy, kind of minimizing what they get when elopement does occur. So for example, let's say that there is a child who is eloping in the store to get to the toy aisle. That might look like providing them labeled praise if they're walking near the cart, maybe letting them carry a toy from home so long as they don't elope. If they don't elope for the whole store trip, maybe you have their favorite toy waiting for them in the car. Maybe they do get to look at the toy aisle. If it's in your budget, maybe you do buy them a toy. Probably not every time, but maybe every few times. Maybe start with just a 2-minute store trip and practice it several times a week. And then if they do elope and make it to the toy aisle, try to remove them if it's safe. Let's say the child's eloping when leaving school to get to the playground. Again, label praise for walking towards the car. Maybe they get a small snack. A lot of kids want a snack after school. Maybe you give them a bag of goldfish that they get to hold on to as long as they're kind of en route. If they don't elope and they make it to the car, maybe they do get to play on the playground for a little bit after they get home. Or maybe there's another really favorite activity waiting for them in the car. Maybe you start by just walking 2 steps to the car and then back in to practice. And then, of course, try to block them from getting to the playground if they do run away. All right, I'm going to skip this last example, but it's in the slides that you all can review. Okay, so outcomes. What we found is that this treatment does work to help kids reduce elopement. So again, this is the randomized clinical trial, half of the kids in the elopement treatment, half in the parent education program. This right here is a score and elopement questionnaire. So it's a questionnaire that caregivers filled out about a bunch of different settings and how often their child eloped from those settings. What you see is the blue bar going down, meaning that at endpoint, the treatment group got better. They were eloping less often compared to the parent education group. We also had parents just score every day whether or not their child eloped that day. You also see a decrease that is more significant in the elopement group. And then again, you see that improvement rating. This is the experimenter that is meeting with the parent and doing kind of a blinded rating. And you see that there was a good bit more improvement in the elopement compared to the education group. Oh, okay. So the summary here is that we find that it is working for about half of the kids, which is great. That's a pretty big improvement from a lot of kids not getting any services at all. All right. I think I'm doing pretty good on time. So we have about 8 minutes left. Let me kind of stop sharing my screen and we can see what questions are coming up. Let's see. Okay. Nicole, I know that I think you're on, and I know you and I have spoke a little bit before about, your experience with elopement. I see a few different comments here. Is there anything that you'd like to kind of add? Are the attendees able to speak up? I guess let me ask that first. I'm not sure how that works in this format.
No, we don't actually have the attendee
Okay.
camera for these.
Okay, sorry about that. I should have said that.
Definitely.
Okay, so I can kind of try to summarize. So Nicole was highlighting in the question and answer that she is autistic and she is eloped. And thanks to some of that, she has been able to kind of live more independently and talking about teaching kind of safe elopement. And I think that that's a really good point that, elopement serves a purpose for individuals. Individuals are eloping for a reason. And so I think figuring out what that reason is can teach them to do this safely. So let's say that, a child is eloping, for example, from school because, let's say a child is eloping from school because they're being bullied. Teaching safe elopement is a good example there. It is appropriate for them to leave the situation that they're being bullied, but there might be strategies for us to teach them how to, elope to a spot in the school that is safe, or how to elope to another adult who is like a safe person. And so I think that's a really good way to put it is, teaching safe elopement. So teaching the child how to get what they want or need in the situation, but without necessarily eloping to a dangerous location. All right. Let's see here. Let me see here. See what other comments are here. The demographics of the participants in the study. I'm guessing that was about the parent questionnaire, and that was it was parents of children with autism. I want to say the age was like 4 to 10-ish, if that kind of answers that question. But I can look that up as well. If you have questions about that, I'm also happy to look it up more specifically after. All right. Trying to figure out the best kind of order to go here. There's a lot of questions, which is great. Let's see. Okay, so questions about the GPS trackers. That's a really good question. So what somebody posted that, asking about some of the GPS trackers, that you've tried some of them, but they just kind of won't wear the watch. The Bluetooth tags are useless and don't really work, especially if you're living in kind of the more rural setting. The suggestion to get your child a phone is a good idea if they will hold on to it. Sometimes if there are preferred activities on a phone, a child is more likely to hold on to it, which can be helpful. However, there are some kids that will kind of take off that device, even if they're kind of wearing it. In that situation, it might be that some of the items that get sewn into clothing are a little bit more helpful. I think that would be kind of my next suggestion if they're removing more of a watch, to see if that's helpful. I think that might be a good first spot. Let me see here. Yeah, this is one of the attendees asked about adults. This is a really good question. Specifically, that a lot of what I'm talking about is working with kids. And you're right. There is less available for adults in terms of these recommendations, especially for adults with significant intellectual disabilities that have a hard time communicating. So for individuals who for adults who, have significant intellectual and maybe expressive and receptive communication delays, I would say that the same kind of general strategies that we're talking about apply. And in the consecutive case series analyses, the call study, there were some individuals that were more late teens in that study, so it does kind of go up that high. But you are correct that we need more research to see kind of which of these strategies generalize to a little bit of older kids. Yeah. Let's see. I see one question about fencing around a house. Oh, specifically like in Canada. I'm not sure if this gets at that or not, but there are so there fencing is a great resource. That way kids can kind of go outside without concern about them engaging in unsafe behavior. Sometimes there are kind of like neighborhood restrictions and things like that prevent that. I run into this most frequently when I work with families that rent and they're not allowed to really like modify their home because of that. I will say that we have had some success with having clinicians write letters explaining, the child's unsafe behavior and like how, maybe some modifications might make the environment safer. And so certainly if you have a child that's working with, maybe a physician would write a letter, maybe a behavioral therapist would write a letter, something like that might be helpful. And then you might be able to kind of get around some of those regulations. Let's see. Sorry, I'm trying to go a little bit in order here. Nicole brought up some of the concerns about trackers, which I think that is worth highlighting again, that, there's definitely a balance between safety and independence, and that's an important balance to strike. The other thing that I'll point out is that if you decide, at age 5, that a tracker is good for your child, given, their level of dangerous behaviors, reevaluate it later. Just because a kid needs it at age 5 doesn't mean that they still need it at 10 or that they still need it at 15. So keeping that kind of balance of independence and safety in mind throughout the individual's whole development is really an important component. Let's see what else here. Teaching an individual to tell a trusted adult. Yes, I agree with that as well. I think that's I think gets to kind of that like safe elopement. So teaching that appropriate alternative behavior that is still getting the individual what they want or need. Exactly. Okay. Any suggestion for elopement to gain access to negative attention? When positive attention is provided, the learner escalates behavior to access negative attention. Yeah, so this does come up. One of the more difficult types of elopement to treat is when it seems like the amount of attention that is needed to keep the child safe is enough that they kind of are going to continue to elope to get that. I'm guessing that in this case you're already doing this, but recommendation number one is always to increase the amount of attention the child is getting for appropriate behavior and to match that to the type of attention that is preferred. So there are some kids that being told good job isn't their favorite form of attention. We all have our specific ways that we want people to interact with us. And there are some kids that kind of like great job attention isn't really what they're looking for. But you might be able to provide, I think what you're referencing there as negative attention in a positive way. Meaning like, can you have time set aside that they get to play games with teachers that are like a chase game or a keep away game or something that might like feel a little bit more like the type of attention that they're getting for elopement. And then if they do elope, they're still going to get some of that, but you can minimize it and kind of maximize what they're getting during the other times. We have gotten creative in this way where we have had like parents play games where they do kind of like they're in a hallway, for example, and like the kids trying to like get past them in the hallway and they're trying to stop them from getting past in the hallway, kind of like those sorts of games for those kids that seem to really enjoy the like chase aspect of elopement. So again, trying to give them what it is they're looking for, whatever that input is that they're looking for, but in the more appropriate way. So that might be something to consider in that situation. Services available with early intervention. That's a great question. So behavior analysts, so it depends on where you're getting your early intervention from. If early intervention services are being delivered by through ABA, the most BCBAs should understand the basics of kind of what goes into this treatment component. We are hoping that the manual will make individuals more confident in implementing them. So I think my answer to is this offered in early intervention? I would say maybe. I would say certainly if you're worried about elopement, asking your early intervention therapist if it's something you can focus on is step number one. If they can't focus on it, then you might look for behavioral providers in your area that focus on challenging behavior, and they should have like a little bit more kind of experience in that area. All right. Let's see. One of the individuals asked if this is happening at school. Yes, if it's happening in the school context, it very much should. Let me start by saying in the United States, I'm less familiar with educational law in other states or in other countries. But yes, in the United States, it really should be focused in on in a behavior intervention plan. And if your child does not have a behavior intervention plan, it should be created. In my experience, I find that kids who engage in elopement and also engage in aggression and tantrums and meltdowns and things like that, it's more likely to get included. Sometimes when kids elope, but it's the only behavior of that category they're engaging in, they kind of fall through the cracks. And so it might need a little bit more advocacy from a parent or from a teacher to make sure that it's being addressed, and to make sure that they're doing that FBA. Because again, we don't want to just stop the child from running away without identifying why they are doing it and making sure that they have that alternative to still get what they want or need.